And good evening. Thank you so much for watching Healthline tonight. I'm Mark Evans here on PBS Fort Wayne. We'll be talking about GERD. GERD is the word. We'll find out what that is and all the other aspects surrounding that. We have a very special guest, his first time on Healthline. His name's Dr. Jeremy Wilson, and he is a general surgeon. Great to have you here.
Well, thanks, Mark.
Thank you. And I know that they probably had to twist your arm a little bit to get you here.
Tiny bit.
Tiny bit.
Yeah.
I see that you're wearing some Purdue colors tonight.
Well, I'm a Purdue grad, and they have an important road game tonight.
So. Oh, yes. And who are they playing?
Michigan.
Michigan, okay. And, of course, we record this show, and we'll be playing it back on PBS Fort Wayne several times. So when you hear that, we're talking about the big event this evening. Yeah. So anyway, we're talking about GERD, and before we get into that and what that is, you are a general surgeon. I always like to talk about some of the qualifications, and also some of the education that you've had. But can you tell us what a general surgeon does? And they're probably going, duh, he's a general surgeon. But what does that encompass?
Well, general surgery, for the most part, deals with a lot of, I always tell folks, soft and squishy things. Intestines, some breast cancers, soft tissue tumors, skin cancers, those sorts of things. If it's brain or hard like a bone, it's probably not going to be us. But
okay, and you discussed in the green room before the show started that you do a lot of endoscopy.
I do a lot of endoscopy as well. I wanted to come back to a smaller area. In Indiana. I grew up in Indiana, just outside of Marion, and just kind of drawn to that area, that patient population, and one of the things that's needed in those areas is somebody to do the endoscopies, the screening colonoscopies, the upper endoscopy for the folks with potential complications of GERD. Mm-hmm. So I was looking for a residency program that was very strong in endoscopy, so I get a fair amount of experience. And be able to hit the ground running when I got into practice.
And I'm sure because of your particular area of specialty that you're quite busy. So, all right.
Quite busy.
We're going to give you a little break tonight, but we're going to talk about what you do. Okay. Instead of having to do it, you're not in scrubs right now. So let's go ahead. What is GERD? GERD.
Well, it's an acronym, stands for Gastroesophageal Reflux Disease. And with it being such a long thing, it's nice to break it down into the little acronym like that.
No wonder they call it GERD.
Yeah.
Okay.
Yeah. Typically the classic definition is reflux of gastric contents up into the esophagus 2 or more times a week. You classify them as having GERD.
Are we finding people are getting that more often these days, or has it always been around, we just didn't know what it was?
It's been around. I think that some things that we're seeing more of now, from our lifestyles and those sorts of things, maybe increasing the prevalence of GERD.
Of course, we have ways to test for it and things like that.
Folks are a little more focused on those sorts of things now, too. One of the complications, and it's a rare complication, so I don't want folks to think that, oh my gosh, I got GERD, so then I'm going to get this.
Right.
It's a very rare complication, but it's adenocarcinoma of the esophagus. And most cancers through the screening programs and those sorts of things, we're seeing the incidence go down. One that we're actually seeing kind of on the rise is this adenocarcinoma of the esophagus, which is a potential complication of GERD.
Okay. And by the way, we are taking phone calls tonight, as we always do. The number is on your screen at 866-969-2720. If you're local, you can drop that area code if you'd like. But give us a call if you have any questions regarding GERD, Gastroesophageal Reflux Disease. And that's probably the only time I'm going to say that during the entire show. Okay, I'm lucky I got through that without messing it up.
You did great.
So we understand what GERD is, but how common is it, and what are the risk factors?
Super common, as you mentioned. Almost everybody experiences at some point some heartburn. Mm-hmm. That's kind of the classic symptom. The 2 main things you're talking about are going to be the heartburn, or pyrosis, if you want a fancy name for it, and then that regurgitation. You don't have to have both, but those are the 2 kind of classic symptoms for GERD.
Okay, and it's not just restricted to adults, is it?
Kids and surprisingly even infants can suffer with GERD. They're a lot less likely to complain of it because they don't know what's going on.
Exactly.
But yeah, I do remember in residency, a lot of times, especially premature infants, for some reason are predisposed to having GERD issues. So
that's interesting. So what are the symptoms? How do you know that you got to get something done?
The main things, like we said, are going to be that burning sensation, some of the regurgitation, some of the more atypical type of symptoms can be even chest pain. Sometimes the pain can mimic heart attack because you get that spasm in the esophagus. People can, if their reflux is bad enough and comes up high enough, can actually cause some issues with throat. Can cause
like a lump in the throat?
Well, that sensation of a lump in the throat, certainly, but more so chronic cough, voice changes, always hoarse voice, always having to clear the throat. Those can be signs of GERD. GERD can exacerbate some other underlying things like asthma or COPD, other respiratory things, if it gets up that high.
Yeah, and I did some research, as I always do before the show, and said more than 60 million American adults have heartburn at least once a month. Mm-hmm. And I probably have it a couple of times because I love spicy foods. But more than 15 million adults have heartburn every day, yeah. Including many pregnant women. Now, why would pregnant women have so much heartburn?
That just has to do with physics. As the fetus grows in the uterus starts pushing up. There's only so much room in there, and it can push the stomach up. If there's a lot of contents in the stomach, it's got to go somewhere, and fluid's going to be pushed up.
I see. Well, that makes sense, and you're right. It seems like it is a physic thing. We have a call coming in on line 5 now. Sometimes, Doctor, our callers don't want their voices on the air.
Okay.
They're shy. There's people who don't mind going on the air, and there are some people who do. But we actually take calls, and we read those off of our teleprompter. And I'm going to let you know that Bays called, mm-hmm. and is acid reflux, is what it says, a cousin to GERD. And it's reflux.
Yeah, reflux. It's basically just a synonym. To me, it means the same thing.
Okay.
That's, when people want to get technical, I guess the acid part of it more is going to be that pyrosis, that burning sensation. GERD encompasses not only that, but then the regurgitation as well. But they're almost interchangeable.
And the same thing, okay. And then we were talking about the symptoms. How serious can this be? I mean, are there some situations where it can get to really bad?
Oh, absolutely, absolutely. Like I mentioned, people forever are going into the emergency rooms with chest pain. Mm-hmm. It's not their heart. It's really bad GERD, causes esophageal spasm. Chronic long-standing GERD can cause narrowings in the esophagus. Food gets stuck. Quite often we get called in then to go do an endoscopy and get that food bolus out. Mentioned briefly the adenocarcinoma of the esophagus. That would be an extreme case. There is a precursor state to that, something called Barrett's esophagus, where the lining at the bottom of the esophagus starts to change to one that's a bit more acid resistant, and you think, boy, that sounds like a great idea. Problem is the potential for it to progress to a cancer.
Okay, so it can get out of hand.
Yes.
And it can cause a lot of damage if it's not treated.
Correct.
Now, we're going to talk about the surgical mm-hmm. procedures here in just a minute because you are the general surgeon, but there are some non-surgical options, aren't there?
Right.
At least you try those first.
Yeah. And, by the time they get to us as surgeons, most of the time they've gone through the list of medical treatments, be that with the over-the-counter medications, the antacids, things like that. Now a lot of the H2 blockers, histamine blockers, and proton pump inhibitors you can even get over the counter. They've seen their primary care doctor. They may even, seen a gastroenterologist or something. Done the traditional is when you first come in, you don't have any of those danger symptoms where, painful swallowing or things getting stuck, especially if that's coupled with weight loss. Those folks need to go straight for endoscopy. But if you're not having any of those sort of danger symptoms, then the traditional treatment algorithm is to go with the lower dose of the proton pump inhibitors for a couple weeks. If that works, fantastic. If not, then you go to standard dose. If that doesn't work, then that's when we start talking about endoscopy to see if there's damage, esophagitis or the Barrett's esophagus or, ulcers or things in that nature.
Not to be morbid, but Can GERD kill you if it's not controlled?
Adenocarcinoma of the esophagus certainly can.
Oh, boy.
You know, that's one of those things, like I said, it's not, most people just have routine benign run-of-the-mill GERD. It's a nuisance, it's a hassle, it can interfere with your everyday life. Very, very, very few people are actually going to get cancer from it, but yeah, it can
happen.
It can happen.
Okay, well, you have to get this taken care of. Telephone number is on your screen, 866-969-2720. We're talking to Dr. Jeremy Wilson, a general surgeon, about gastroesophageal reflux disease, also known as GERD. So, I found out too that there are some medications that can aggravate the symptoms of GERD. Would you talk about that?
Well, there's medications, there's just some lifestyle things. We always tell folks if you're a GERD sufferer, you want to avoid smoking, you want to keep your weight healthy. The classic triggers, like you mentioned, spicy foods, other things, caffeine, carbonated beverages. A lot of folks have trouble with tomato-based stuff. Mm-hmm. Then we start talking about some of the medicines that can make things worse, some over-the-counter things like the ibuprofen, Advil, Aleve, naproxen, aspirin. They can make GERD worse. They can give you ulcers. Some of the blood pressure medications can actually lower the tone at the bottom of the esophagus and can exacerbate GERD problems.
Oh, wow. I didn't think about that because I am on a BP medication myself.
Not all of them do it, but some of them can.
Okay, well, I'll keep an eye on that. And you mentioned the pain relievers. It could be what we call it a double-edged sword. If you got GERD and you say, "Well, I think I'm going to take some Tylenol or some ibuprofen or something," a pain reliever. Yeah. I mean, that could actually aggravate it, can't it?
Tylenol, not so much, but ibuprofen certainly can.
All right, and that's something too, and that's another subject that even my physicians have said, take the medication that starts with a T. And don't take the other one.
Yeah.
All right, we have another call coming in, and it's Paul, and he's asking to stay offline, but Paul will be more than happy to read your question. Paul is asking, is coffee okay for someone with GERD, and is there a special diet I should stick to? Good questions.
Right. Coffee is one of those things where it goes back to caffeinated, and then caffeine can worsen reflux symptoms. What I tell patients is if you can drink coffee and it doesn't bother you, okay.
Okay, good.
But not everybody can. Tell folks too to stay away from those classic triggers: caffeine, carbonation, chocolate, mint, spicy foods, and any personal triggers. Somebody might say, if I have onions, I'm going to have terrible reflux tonight. Mm-hmm. Stay away from those if that bothers you. I think
that's more or less this whole thing is an individualized thing. It's not
very much.
The same symptoms aren't going to show up in everyone.
What you would describe as heartburn, somebody else may describe as something else. So yeah, the symptoms are going to be individualized. A lot of times treatment plans are going to be individualized. There's some base work that you do, but then you kind of gauge based off of patient response and either add something or delete something or change to a different medicine or take it at a different time.
Okay. So change the schedule on that a little bit. All right, so we've talked about the medications. When, as a surgeon, and first of all, before they come to a surgeon, mm-hmm. who are they going to see besides their family doctor, or will there be anybody else in between?
A lot of times not. Like I said, I do a lot of endoscopy, and so that's typically the point where I'll pick up a patient, because they've tried over-the-counter medications, they've tried the usual treatments through their primary care, and they're just not working. Okay. So then we start to look for the complications, the Barrett's esophagus, the ulcers, the strictures, get a gauge on hiatal hernia, which can make reflux symptoms certainly worse.
Now, what is that?
Hiatal hernia, basically what happens is that there's what's called the diaphragm, which separates the chest cavity from the abdominal cavity. Well, there are things that start up here that need to get down there, one of them being the esophagus. So there has to be an opening in that diaphragm for the esophagus to get through to attach to the stomach. That's called the diaphragmatic hiatus then. Mm. Hiatal hernia happens when part of the stomach or something else herniates through that up into the chest.
I see.
Again, like we were talking about physics. Fluid's going to follow physics. It's going to go from high pressure inside the abdomen to low pressure inside the chest. So it's just going to exacerbate and make things easier for things to come up, exacerbate any GERD symptoms. Depending on what else, if anything else is in there, could even become painful. Stomach can rotate on itself.
And there's something else I wanted to ask you about, if I could find it real quick here. Let's see. It was about how people can keep food in their stomach longer than others. Delayed emptying of the stomach. What's that called?
That's called gastroparesis.
Okay.
Basically, the stomach is paralyzed or not functioning as you said normally should. There are certain things that will predispose somebody to gastroparesis, diabetes being one of the main culprits.
Interesting.
And even some of these newer diabetic medications like the Ozempics and things in that nature will actually almost induce a gastroparesis, and that's kind of how they help you lose weight, because you feel full all the time. Your stomach doesn't empty well.
Yeah. Is that common?
Gastroparesis?
Yeah.
I think it's more common than what we realize. There are a lot of times we'll see somebody for GERD and we'll end up scoping them, and they're the traditional is you don't have any solid foods for 8 hours before the procedure, no liquids for 6 hours before the procedure. We get the scope down in the stomach, we still see food
It's still there.
Yeah.
Wow. And that's not necessarily a metabolistic thing.
No, that's just sometimes the innervation to the stomach that causes it to squeeze and propel content. Sometimes it's a medication side effect.
Okay. All right. That makes sense. All right. We have another call coming in, but before we get to that, as we're loading that question up, I wanted to ask you, we've talked about the medications and non-surgical types of procedures that we can at least try. And how successful are those? We mentioned the groundwork that needs to be laid to treat GERD. Yeah.
And if it's just like building a house. If you build a house on a poor foundation, it's not going to stand long.
I see.
So you got to build that solid foundation, and that's, exercise, avoiding those, triggers, keeping your weight healthy. Then you start adding to that the medications and.
I see. Yeah, you got to get what you call a baseline and figure out and go from there.
Yeah.
So it's not going to be in some cases, in many cases, it's not going to be an overnight cure, overnight change.
In most cases, in almost all cases, it's not. Because even with the medications, it's going to, if you have an erosion in the esophagus or something, it's going to take that several weeks for it to heal.
Okay.
So you're not going to notice dramatic symptom relief with the first dose of a medicine.
All right. Before we get into the surgical procedures, Mr. General Surgeon, we're going to go ahead and talk to Rose here. Rose is asking a question. She said I had AMER visit due to, I guess a morning ER visit due to esophageal spasms, and was this because of GERD? And will any of the medication to treat this give me worse acid reflux?
Those esophageal spasms certainly can be related to reflux. Interestingly, they respond to the nitroglycerin just like chest pain would, because that esophagus is just a tube of muscle and it spasms down. Nitroglycerin is going to allow that to relax.
Okay.
So, medications for the spasm, it's going to depend. Like I said, certain medications that are classically used for blood pressure treatment can also relax those esophageal spasms, but in the process could potentially worsen GERD symptoms.
Okay, well that makes sense actually, since you laid it out that way. All right, well let's get into the fact that you go through all the medication, you try these various things, and of course the last thing anybody wants to do is have surgery.
Right.
But in some cases, you have to do it. So what are we talking about there?
Surgery usually is reserved for the worst of the worst. Like you said, they failed lifestyle modifications, they failed the over-the-counter medications, they failed prescription medications, or they have some of these other complications, be that Barrett's or, early stage cancer, those sorts of things. There are different procedures that can be done to help with GERD symptoms. Some less than surgical, we'll say.
Okay.
There's a procedure called a TIF, which is a transoral incisionless fundoplication, which is done endoscopically, where they go in through the mouth into the stomach. And all of these procedures are designed to increase the pressure at the bottom of the esophagus, where it meets the stomach, and the idea is to have a high pressure zone, make it harder for things to come up. So fundoplication involves actually taking the top of the stomach and wrapping it around the bottom of the esophagus and suturing that in place.
Okay.
So that can be done with this TIF procedure, which is the endoscopic one, or it can be done surgically. There's a newer one that actually is a magnet that can be implanted.
Is that right?
Yeah.
Now, explain that. That's fascinating.
Magnetic augmentation of the sphincter there, and it's just a ring of magnets that they put around, and it causes that area to kind of almost narrow off. It's not one that you're going to see, being performed a lot in a community hospital. This is going to be one that's done more in university centers. And
this is
things
for
like
the
that.
more serious cases.
Almost all of these procedures are reserved for the absolute worst of the worst,
Okay.
because the procedures by themselves aren't benign. There are complications that can come from procedures. Any surgery is going to have complication, but with the reflux procedures especially, there's what's called a gas bloat syndrome, where you actually lose the ability to belch or vomit. So you can eat and then you just bloat up and feel miserable, and also a fair amount of failure with some of the surgeries. Up to a third of people can be back on medications within a year after an anti-reflux surgery. So it has to be done on the right person
At the right time.
at the right time. Yeah, and there are other tests that need to be done before you go to a surgery. The pH probes and manometries and things like that to see if you're a good candidate for any of the anti-reflux surgeries.
Well, that makes a lot of sense. All right, we have another question coming in. Let's see. I think it was just a tag on to Nancy's question before. So this is actually a question that I was going to ask you.
Yeah.
Doctor, it says, when should you go to the doctor with these concerns?
Anytime you have chest pain, be it cardiac, be it GERD, chest pain you don't play around with. You get into the emergency room right away.
Yeah.
Other things, GERD-specific things would be, mentioned trouble swallowing, painful swallowing, especially if that's coupled with some unintended weight loss. You need to be seen right away. Get that looked at, be that through upper endoscopy or an upper GI x-ray, because those are some of the warnings that you could have a stricture or, worst case, esophageal cancer.
Well, and you said you need to be seen right away so that you don't jump the gun. I mean, for instance, if you were on a new diet and for some reason that particular food was causing, or some of those foods in a new diet plan were causing these issues.
Right.
So I guess the first thing you need to do is actually go to your family physician and
Yes.
say, I'm having these issues.
Yes.
And then I guess they'll of course sort it out from there. Figure out what your food intake is.
Yeah.
Does stress have anything to do with this?
There are different triggers for acid production, and one of them is what's called the autonomic nervous system, and that can be tripped off, I guess, by stress.
Okay.
So everybody thinks, I'm stressed out, so I'm going to get ulcers.
Yeah.
Probably not, but
I grew up with that. You
Yeah.
don't want to get too stressed out because it causes
You're
ulcers.
gonna get
but
an
that's
ulcer.
not true, right?
We found over the years one of the main culprits for ulcer development is actually a bacteria that can grow in the stomach. Up until we learned about that, people were having surgery all the time for ulcers because they couldn't get them treated.
Yeah.
You give them medicine, but it just come back. We found this bacteria, and so now we treat that bacteria, eradicate it.
And where does that bacteria come from?
It's in the environment. People just pick it up.
Oh, I see.
So, and then mentioned also, the non-steroidal anti-inflammatory medications, ibuprofen, aspirin, Advil, those things are also some of the main culprits for ulcer development.
I guess so. So you go through all that and go to the doctor, and of course they're saying, well, there's not a whole lot I can do for you. I'm going to have to send you to get a scope done. And of course, that would be the role you play.
Yeah.
And then if anything else in addition to that after the scope, you would also, in some cases, most cases, take care of that as well.
I personally don't do anti-reflux surgery. I did back in training, but anti-reflux surgery is one of those things where if you don't do a lot of it, you shouldn't do any.
Okay. All right.
For those reasons that we mentioned, you wrap the stomach around the bottom of the esophagus. If you wrap too tight, then you get the gas bloat. If you wrap too loose, symptoms come back. So you need somebody that does a lot
All right.
of these.
Well, listen, this has been very, very educational. We appreciate all the phone calls from the viewers as well. That's why we do this show. It's what we do. So, and I don't think we've ever talked about GERD on this program. So I'm glad we had this chance. And I would like to have you come back some other time. We'll talk about some other issues
I'd be glad
that
to do
people
it.
will encounter. Hopefully not, but if they do, we know how to take care of those.
All right.
All right, Dr. Jeremy Wilson, General Surgeon, talking to us tonight. Listen, we'll be back next week with another very educational, very informative show, so please join us 7:30 on Tuesday night. Until then, you can always watch us with a special note, this and other episodes on YouTube. Until next time, good night and good health.
The preceding program on PBS Fort Wayne was made possible in part by...
It's a new day at Parkview, another day to rise up and make life better for those around us. Whether that means pushing the boundaries of what's been possible, taking big strides, or sitting with a patient long after a shift has ended. At Parkview, we don't just do what's expected. We do what's best for you and your family. And we're determined to do it even better tomorrow. Every person, every day. That's the kind of healthcare we believe in. Parkview Health. We believe in better.